Hello, and welcome to the Movement Prescription Podcast with a bit of a difference. I'm Callum. I'm one of the hosts alongside Hussein and Susie of the usual podcast. I'm also a GP and a researcher at the University of Dundee. Over the past year, I've had the incredible opportunity to travel internationally as a Churchill Fellow, exploring one simple but powerful question: how can primary care do a better job of helping people become more physically active? First of all, what is a Churchill Fellowship? The Churchill Fellowship is a charity set up as a legacy of Winston Churchill that funds any UK citizens to travel globally to find global solutions to local problems. If you don't know about it, give it a Google. It's a wonderful opportunity to pursue your passions. Now, we know, and if you're listening to this podcast, you're probably aware that physical activity is a really effective way of improving health and well-being. It can prevent many long-term conditions, support mental health, help people live longer, healthier lives. Yet, despite the overwhelming evidence, physical inactivity is a growing problem globally. We also know that talking about physical activity in healthcare settings, a GP discussing it with their patients, can improve patient physical activity levels. And yet, despite that, it's frequently not being done. And so, through my Churchill Fellowship, I visited organisations, healthcare professionals, researchers, to try and find out how physical activity was being promoted in different places. I travelled to New Zealand, Australia, Finland, and the Netherlands. My journey started in New Zealand. Why New Zealand? Well, it's always felt to me like there's a culture of physical activity, at least in many parts of New Zealand. I recorded these interviews after returning with some people I met on my journey to give a flavour of the travels. And something at the start of this very first interview, Andrew confirms, is that there's a culture of physical activity, at least where he is. For those that have listened to the Movement Prescription Podcast from the start, Andrew Boyd is a familiar voice. He was on our very first podcast. He's a British GP with a passion for physical activity and lifestyle that moved over to New Zealand a few years ago. Andrew, thanks so much for joining. I was wondering if you could tell us a little bit about physical activity promotion within healthcare settings in New Zealand, in Wanaka, where you are.
Well, where I'm in Wanaka, I don't know anyone who's been to Queenstown or Wanaka in New Zealand, but it's a very active place anyway. So I think the biggest difference for me, coming as a London-based, NHS-based GP, where I was banging on about physical activity to anyone who would listen, which was mainly not very many people. It's pretty different because people are actually very active here. I still mention it in a lot of consults because I sort of pretty hardwired to do that after many years of banging the drum. But in fact, it's more often. I remember we were taught, and then I taught lots of the people that when I was teaching about physical activity in the UK to say not what sports are you into, but how active are you? And actually, here you can just say, what sports are you into? Because most people, whatever stage of life they are, will be doing some kind of physical activity. And so it's kind of quite a lot easier here. And in fact, what I see a lot more of is people who are injured as a consequence of being possibly too active, or at least being too fast doing something active, and the sort of fallout from that. And I guess what it's made me appreciate is seeing lots of people who are injured and therefore sort of temporarily bereaved of their physical activity, how much their well-being drops as a consequence. So you're almost seeing it sort of in reverse, I guess.
Yeah, interesting.
And that's quite interesting. Yeah.
Yeah. One of the preconceived ideas before I came out and visited was that the culture in places like New Zealand and Australia was much more active than the UK, more generally. And visiting you in Wanaka, that was definitely the case. But do you feel it's kind of a bit of a microcosm in Wanaka? Is that kind of increased level of activity at a population level more generalised throughout New Zealand?
Well, I think the stats say that it isn't a microcosm of New Zealand. I think the physical activity rates are, from what I've read, marginally better than the UK, but obesity rates at a population level are very similar, if not actually a bit worse than the UK, possibly influenced by certain ethnic groups who just have a genetic predisposition to having a higher BMI. But I mean, ultimately, what I've seen in New Zealand is this pretty much the same as I've seen in the UK and other countries, which is if you're broadly, this is a broad generalization, but if you're a have, if you are economically and socially secure, then you can go up to the next step on Maslow's triad and be more active for your own well-being, and you've got the financial and other wherewithals to get active, and that's the challenge. There are certainly, I know from colleagues elsewhere in the country, that there are pockets of New Zealand where inactivity and obesity and all the things that we know kind of follow on from that as a consequence of those behaviours is rife, and it tends to be in more urban settings. And of course, New Zealand, just because of the way it's geographically more spacious, there are fewer urban conurbations, but certainly in South Auckland, particularly in pockets of Wellington and other places in the country, there's definite levels of deprivation and inactivity which go with it.
Interesting. And you mentioned that it's quite similar to the UK in terms of the physical inactivity in many ways. Is it the same with the approach to health promotion within primary care? I know that the primary care setup is broadly very similar to the UK as well.
Yeah, I think we have a little bit more. The model here, again, for people who don't know, is that there is a capitation model. So GP practices are part funded by the government, but many of them are also kind of part private model. So patients pay a fee every time they see a GP, which does change the dynamic in some ways for the better, in some ways for the worse. But it's a slightly different model. But by and large, it's a very similar model, and NHS GPs would slot in relatively easily, with a few caveats, into the New Zealand model. But there is less target-based approach from a government level, so we're not mandated to do as much kind of data collection, and we're less target-driven than in the UK, which again, depending on which side of the coin you're looking at, can be a good thing or a bad thing. It means that, in my experience, patient consultations tend to be more patient-focused and less focused on targets and other things on the sort of dashboard that I remember from UK practice. But also perhaps we don't always practice the most evidence-based medicine as a consequence. And certainly, as I say, part of my kind of built-in history taking includes a question about physical activity. So it does come up in most, but not all consults. I don't know whether that's true for all of my colleagues. I imagine probably just like in the UK, there are those of us who are particularly passionate about physical activity and recognise its importance as a risk factor, or inactivity for a risk factor for health, and we bang on about it a bit more. How effective that is, we don't know.
What's your question, Andrew? What's your built-in? Do you have a question you ask?
Oh, well, as I say, I used to say, how active are you? That was my question in the UK, because it was a very non-judgmental question and didn't assume that people were into or could access sport in the kind of defined sense of the word. Where I work now, which is a privileged, active community in the South Island of New Zealand, where there's a lot of green space and a lot of sunshine and a lot of water, I say, what are you into? And people normally respond to that very open question by telling me the sports that they like doing and how much of it they do it and how competitive they are.
I remember when we were through, you were telling me the story of parents dropping into their kids' school and you were one of the few without an Olympic medal.
It is a bit like that. It is a bit like that. And a really positive thing here, and again, this does come from ultimately a place of privilege and access to things, but there are quite a lot of disabled athletes, including quite a lot of Paralympic athletes in town as well. And I think that's really inspiring for other people. I've got a couple of, because people engage in high octane activities, I unfortunately have a few patients who have had life-changing injuries as a consequence of the sports that they're into. And I think it's really positive to have other role models, people who have injured themselves in the past or have been born with other disabilities and still being engaged in sport at a really high level. And yeah, I know some of my patients are pretty influenced and motivated by seeing those people getting out and doing stuff.
Interesting. Malcolm Gladwell, the author, talks about the tipping point, and he predicts it's about 25% of a population. If 25% of the population doing something, it kind of drags everyone else along with them. And it sounds like maybe that's the case in Wanaka. You're kind of the odd one out. You're the weirdo if you don't exercise, and so you kind of feel social pressure to do it. Moving from kind of delivering physical activity on an individual basis, which from my experience in the UK, that is often the case. There's kind of passionate individuals that will talk about it and push an agenda. Has there been much of a system approach in New Zealand? I know from reading and from kind of academia, there was a thing called the Green Prescription, which was set up in about 2000, I think, which was really popular and had quite a good evidence base. But when I was out, it sounds like that had been defunded or in certain areas had been defunded.
Yeah,
and maybe
I think it's been defunded in certain areas. And just like a lot of these shiny initiatives, once they've kind of lost their gloss and people have moved on to something else, it's difficult to kind of continue to be so excited about them. But it is still going in some places for sure. And that's basically a model where a practitioner can recommend some physical activity to someone, and then there is a system within the community, sometimes based out of the GP practice or sometimes based at a sort of council level, where they can signpost that person to, and they have access to lower cost, more accessible physical activity. And it's obviously aimed at the people who have the most to gain, which is typically the people who are least active and who have existing chronic diseases. I think a big thing in New Zealand is, Kiwis do pride themselves on their love of sport and getting out in the beautiful, great outdoors here. And councils and, governments and, the powers that be do put emphasis on that. So it's, so most towns will have, decent amounts of green space, decent sports facilities. Most towns of any size will have a swimming pool, will have really good playgrounds, and all that stuff really matters, right? For people getting out and about. And the schools themselves put a high import on high level of importance on physical activity. So, for example, my kids' school, and my kids are 5 and 7. Every single school in the area takes part in a sort of mini triathlon when the Wanaka Challenge Triathlon is on. So the main event is on the Friday and the Saturday, but on the Thursday, all the kids in all the schools come and do a non-competitive, by which I mean slightly competitive, swim, bike, run. And for the little kids, they're just splashing through the water, and then they're doing a bike and a run. And for the older kids, they're doing a proper swim, bike, run. And the whole town turns out for that, and that's really it's a really big deal for the kids, and they all get a medal and that sort of thing. So there's that kind of thing that moving in your community, moving outside is important and worth giving up school time for. I think certainly there's a feeling amongst lots of people, including lots of parents, I think, in the UK, there's so much focus on academia that kids, that PE, as we used to call it, and sports get squashed a bit. And that's not the case here. I think the kids are pretty active. Again, case in point, and again, it's because we have these facilities on our doorstep. But for the entire term, when the ski season's going, each school has a day where the whole school goes up the mountain. So they miss a day of school, but they're learning about other stuff, about being resilient, about obviously skiing itself, but about having to have all your stuff together. If you forget your gloves, it's your problem. The weather's not always very clement. And they all go up and come down, and they're absolutely knackered at the end of the day, but they've had a good time. Obviously, that doesn't happen everywhere in New Zealand, but it's that kind of attitude that means that New Zealand, overall is more physically active than some other Western countries, and also punches above its weight when it comes to sporting achievements on the elite stage as well.
I think that's a really interesting, possibly a really interesting point to kind of finish on. Is the physical activity promotion in primary care is similar, but actually we in primary care have a bit of a limited impact. We're quite a downstream determinant, and to have a big impact addressing things in a much more systems-wide approach, and actually starting with kids is a great place, and having infrastructure. You mentioned playgrounds and parks, and actually it's a much wider, much more politically engaged and community engaged approach that will have a big impact. So, look, Andrew, thanks so much for joining. I really appreciate all your thoughts. It's been really valuable.
Not at all. Pleasure.
As Andrew nicely illustrated through the example of his children and the culture of physical activity within the schools in New Zealand, a community-wide and systems-based approach is required to address the issue of physical inactivity. As pointed out to me in my next stop, Australia, primary care is a downstream determinant of population-based physical activity. I was told not to overstate the importance of physical activity promotion within primary care, with other interventions like the promotion in schools and the establishment of infrastructure often more important. Now, this is not intended to be nihilistic. Primary care and the promotion of physical activity within primary care definitely has a role in the prevention and treatment of many long-term conditions. But for this to be maximally effective, the environment needs to be right. For example, if I see someone in my clinic that is struggling with knee arthritis, and we agree that actually them getting on their bike might be a really helpful way of managing that condition, but there's no cycle lanes, things are unsafe, and actually access to bikes isn't great, then it's pretty unlikely that they're going to be successful. To give you a flavour of what's happening in Australia, I've gone back and recorded an interview with Tracy Johnson. She's quite a prominent figure in Australia and is CEO of Inala Primary Care, a primary care network based in Brisbane. She's instrumental in creating a number of innovative healthcare models and is the founder of Kui Health. Tracy, it's great to have you. Thanks so much for joining today.
It's so lovely to see you again, Callum. I remember catching up with you when you were over here as a Churchill Fellow, and again when I had the privilege of seeing all of your good world in Scotland last year.
Oh, no. Hopefully we're again soon. Either me in Australia or you over here again.
Oh, yes, please.
Yeah, Tracy, I kind of... Yeah, look, I'd love to pick your brains on physical activity promotion within Australia. One of the reasons that I wanted to go to Australia during my Churchill Fellowship was that from an outside perspective, Australia feels like a really sporty place. It's kind of an overachiever on the global scale from sporting events, particularly considering that the national sport is Aussie rules and no one plays that except the Australians. But despite that, it's kind of become evident to me that actually the issue of physical inactivity is as big in Australia as it is everywhere else. And so when sport and being active is such an integral part of the national psyche, and yet the inactivity is a big issue, what is happening at a government, whether that's kind of national or federal level, to try and address the the challenges of inactivity in Australia?
Look, many things. This is a big and active conversation. So like in other parts of the world, the social determinants of health are real. So what we find is not only is activity and inactivity spread differently across the country, but it's disproportionately evident in poorer communities. And the building that I'm sitting in is in a social housing community in the western suburbs of one of Australia's major capital cities, a place called Brisbane. So what we find is that obesity and lifestyle challenges promulgate in communities with less assets, and that those communities, if I think of the one that I serve here in Inala, we have less sporting clubs because there's less social capital in this community for people to band together and create a soccer community or a cricket club or any other sort of thing, because they're not trained people by and large. And so, getting a not-for-profit entity up and running, or I think you call them third sector entities in your part of the world, is harder. And, finding people who might donate land or councils who might, provide land and advocating for that is something that communities like this have denuded resources to do. But in terms of who's doing what, Australia has this funny governance system. So we have local councils that look after sort of the areas that you live. Then we have state governments who look after, a bit like England, Scotland, Wales. We have these states who also have governance. And then we have a federal government. So primary care, preventative care and some of these things are actually a federal government issue. And yet they don't have reach right down to community grassroots level because that's councils and state government. So we've got this funny challenge with our governance model, which we're not going to solve in my lifetime. But what we know is that local councils have very much picked up the agenda, and they're starting to say, it's a race to get people to come and live in my community because we've got workforce shortages and, we want to improve our council area's reputation, etc. So providing public parks and public spaces that people can do all sorts of good things is becoming a very strong agenda for local councils. For health service providers like the one that I'm part of, the College of General Practitioners here in this country has been a very active supporter of park run movements and other organised programs, and they've created brochures and things like that GPs can give to their patients when they're doing social prescribing. We're a land of lots of big, vast open spaces, so we've got at a state government level big movements around more national parks, more walking parks, more bicycle-friendly areas, lots of big bicycle pathways and the reuse of old disused railway lines and all that sort of stuff to try and get activity happening. And then I think there's this big movement of going, well, activity doesn't have to just be about getting hot, sweaty and big muscles. So, what are the sorts of activities that get you going? And one of the things that I hear being said by our team most often is, what is the best form of activity? It's the one that you're going to do. So it doesn't matter whether you love cycling, going to the gym, gardening, whatever. Just get out and do something on a regular basis that you find fulfilling. So I think changing people's mindsets that it's not about the beach body that Australia is quite famous for. It's about regularity and intensity of exercise. Our challenge is, of course, that worldwide, all of the guidelines and science around what is good and appropriate exercise keeps changing, so it can be a bit difficult for people to understand that. So we've done some interesting things in Australia about walk-to-school movements, school walking buses where you park a bit of a way away and, have volunteer parents that walk the kids to school, because we've very much become a country of car drivers that drop their kids at school, whereas when I was growing up, you used to walk to school. So we're trying to make roadways safer so that kids can transit to school more easily. We're also, I guess, looking at what are the reward mechanisms. So private health insurance, which is a big thing in Australia, a little different to the UK system, can provide incentives for you to buy exercise clothing and participate in gyms and various other active things. So, there's certainly lots of people in the healthcare system, in government systems, just at a community level going, we've got to get more active. And there's certainly big moves in the mental health space as well to try and pair what we can do to support people who might have fragile mental health or ongoing diagnoses of mental health issues with activity, cancer survivorship as well. How do we use activity in cancer care? So, as I said, there are many voices, many players, many things happening. Is it happening often enough? Not terribly. But I can certainly see that the trajectory is heading in a direction.
Really interesting. Lots of interesting stuff you mentioned. One I'll pick up on is the fact that actually the fact that Australians are viewed as so healthy and the beach body can actually be counterintuitive in some ways for people that kind of maybe feel guilty or feel that it's unrealistic for them. Pulling the conversation from a kind of a more general one, specific into healthcare settings, you mentioned some things already, but is it commonplace for clinicians in primary care to discuss physical activity with patients, and are there any pathways or programs in place to support that happening?
Yeah, so like you, I'm a Churchill Fellow. So I came to Scotland in 2015 to look at Glasgow, interestingly enough. That was my first experience of Scotland, and it was a positive one. And at that time, they had 7 GP practices. That by the time I actually physically arrived for my Churchill Fellowship was 15 GP practices who were involved in social prescribing. And one of the things that the UK should be proud of is that Scotland and indeed the UK have led social prescribing movements around the country. So one of the things I studied in my fellowship was what was social prescribing and how was general practice getting involved. So upon returning with my fellowship, I guess I've tried to lead the national conversation here around what does social prescribing look like, and I've had the privilege of piloting things, doing research papers, doing policy papers, and getting involved with a bunch of other advocates that have really seen that social prescribing needs to become mainstream. Our challenge is that a lot of clinicians still see social prescribing and signposting as the same thing, so that quick reference to, hey, you should get active more and whatever, as opposed to how do you really work with the patient through motivational interviewing and link it to their health goals and actually get a proper social prescription happening. Unlike the UK, we haven't had exercises where people have been given, vouchers and other incentives linked to their healthcare and other insurances to really, really drive change. We have had a growing role within government to provide funding to disadvantaged families so that their kids can get involved in sport, for example, because we know that if kids have an experience of sport, it's more likely to become ongoing. And then to our health promotion agencies. We have a group called Health and Wellbeing Queensland in the state that I'm in. They've been doing a lot of place-based work at a community level about, what are the assets around here? What are the interests of people around here? How do we get people outside, active and connected? And a lot of those pilots have gone very, very well. So now what we really need to do is embed within general practice the link workers and other enablers of that sort of support so that it doesn't become a doctor task or, dare I say it, even a nursing task, because they're in pretty short supply. We've got to have all of these other people that know what's out there and can link people to that, including the likes of these government vouchers to get your kids into a sporting club of one type or another. So I certainly think that there is growing interest. There's growing publication rate in this country. We've started developing a software system to start enabling those things, which we've put into early phase trials, and hopefully next year will be a bigger thing. And I think the College of General Practice has played a really critical role in this country. They've created a special interest group and have really partnered with myself and others to drive the policy change and the advocacy around social prescribing, which we had thought, as government increasingly funds teams in care environments in Australia, we've got a very doctor-centric, doctor-led kind of healthcare system here, much more so than you guys do. But that is something that government is looking at, and we're looking to do a lot more in, had we not had the war in the Middle East in recent times, which has affected the way the government is looking at budgets. But I remain optimistic that over the next few years, we're going to see more and more and more attention to this in healthcare settings themselves.
And you mentioned that there is some resistance from clinicians, and one of the things that came up when I was over there was kind of about incentivizing them and what that might look like. And actually, I think there's been very similar conversations in the UK as well. Often, time is precious, and And financial remuneration might be an avenue with which to incentivize the delivery of physical activity promotion or social prescribing. And particularly in Australia, you've got, with the kind of slightly different healthcare system and insurance system, Medicare was something that came up, and it had a Medicare number. Could you talk to us a bit about that and what the significance of having a Medicare number and whether kind of financially investing in this would have a big difference on it being delivered or not?
Yeah, so in 1984, Australia embraced a national insurance scheme called Medicare. As the name suggests, Medicare was largely about providing subsidised access to doctors and to hospitals. So since that time, I guess the medical lobby group has had a stranglehold over an awful lot of the decision-making around where does care go and what is care like. And I think for many clinicians even now, getting their heads across lifestyle factors, lifestyle medicine, social determinants, it's perhaps not where their training was at many, many years ago. So we've not seen as bigger expenditure on preventative health in Australia as you have in your country. So we spend about 2% of the total healthcare budget on preventative health. You spend about 6% or something like that. So there's a disproportionate lack of expenditure on preventative health and public health agencies in this country. On top of that, we don't have a capitated funding model in general practice. What we have is a volume-based funding model. So Medicare works when you see a patient, and it normally has to be a doctor seeing that patient, and we get paid different amounts of money depending upon how much time we spend with the patient. So if you don't have the patient in front of you, you don't get paid, and if you're not able to record the time that you spend with them, you don't get paid. The incentive in the system, when it was built way back in 1984, was to not spend too much time with the patient, which makes sense. I'm a health economist too. I wouldn't want to pay doctors to sit chatting to patients about a patient's dog training hobby or something. It needs to be a reasonable clinical conversation. So not surprisingly, the longer the consult you spend, the less per minute you get paid. Now, a lot of doctors in Australia are under time pressures, just as they are in the UK. And they're kind of like, well, I'm a clinician. I'm here to do differential diagnosis and come up with management strategies. I'm not really good at all of this soft and fluffy stuff. So I'll make a mention and move on and get the next patient in. That could be okay so long as we had somebody else to delegate the care to, whether it's a nurse or a link worker or a social worker or something like that, which at the moment we don't have the luxury of having too many of those resources to call upon. But as I said, there's a tipping point that we've reached, and I think that's going to change. Look, as a health economist, what I know is that any funding model can be gamed. Any funding model can be blamed for the results that you get. But an activity-based funding model is particularly cruel and harsh when it comes to preventative health, because unlike the QOF model that you have in the UK, where there are certain quality for outcome measures that you're tracking, in Australia we don't do that. We don't actually have measures that we have to sign up to and track against, which is, again, in the process of being reconsidered and changed. So as those things start becoming a bigger part of the way that general practice workflow occurs, I can see that, again, a focus on activity of all types, social connectivity, physical activity, healthier eating, etc., will become a bigger thing.
Interesting. Yeah, that's really fascinating. And picking up on the often the way that the funding system prioritizes seeing GPs and often not other healthcare professionals is a really pertinent and interesting one, because one of the things that was interesting in Australia was that they're world leading regarding clinical exercise physiologists. You'll know a lot more about this than me, particularly because your son is training to be one, but they're exercise specialists that are trained to deliver physical activity to people with chronic health conditions. And so yeah.
Interestingly enough, the building that I'm sitting in right now was actually the building where exercise physiology got started in Australia. So it's a weird history. You didn't know that was going to come up, and I didn't know it was going to come up. But so exercise physiology actually got developed and piloted in this building, where community health staff, allied health staff associated with the local hospitals who were running rehab clinics and chronic disease support services, identified that there was a gap, that when people were doing pulmonary rehab, cardiac rehab, those sorts of things, of course, exercise and increasing exercise was part of the treatment program for those patients to give them confidence to get back out and doing good things. And they realised they didn't have enough physios and they needed a different skill set. You know, the combination of sort of that biomedical scientist who's able to look at machines that go bing and the biomarkers that they're telling you are being driven in the patient as they exercise at certain rates, as well as sort of physiotherapy, podiatry, health coaching, you know, a whole range of disciplines could actually work really, really well with patients in rehab. So that was piloted here in this building, was incredibly successful, led to some other pilots and ultimately to the creation of exercise physiology as we know it. You're right, my son is actually doing exercise physiology as an undergraduate at university. So he, unlike most Australians, does not have an exercise deficit in his life. He's hyperactively involved in exercise of all types and has the body to prove it. So what exercise physiology is becoming now in this country is a really interesting discipline where, yes, some of them work in cardiac clinics and hospital rehab labs and all of that sort of stuff, but a lot of them are found in community gyms. They're found in private health insurance groups that run like community wellness hubs. Some of them are found in general practice settings where they're involved with patients for one-on-one support programs. So they can be found in a whole variety of places and spaces. They're still not widely understood by the community. Physiotherapy is understood more widely in the community, for example. And yet one of my team members here moved out of hospital settings. He's a trained physio and was working in an organisation that was setting up sort of privately funded health hubs for people over 50. So that if you didn't feel like, you know, putting on a little piece of Lycra and turning up to a gym with all of those beautiful people, you could go somewhere that was a bit safer and still improve your health and well-being. So they had, you know, gym instructors, physiotherapists, dietitians, and exercise physiologists and psychology all sort of combined into these private health insurer-funded health hubs. Simon reports to me quite faithfully that he thought the physiotherapy option would be the really, really popular option that would get way better results with patients presenting with, you know, our biggest presentation type in general practice, lower back pain, all of that sort of stuff. What ended up happening was, in fact, the exercise physiologists got way better results with these older Australians. So the mix of staff that they had, I think they have 15 facilities in the state that I'm in, up and down the coast. They've ended up dismissing some of the physiotherapists because they were just not as popular and employing more exercise physiologists because the patients found them a whole lot more approachable, a whole lot more broader skill set because they're not just here to solve the problem with that muscle. They really are looking at biomechanics, lifestyle, activity levels, all of the reports that they can get out of scans and histories and interventions that you've had done. So, yeah, it is actually a rising and attractive career. Some of them go on and become super expensive personal trainers. Others of them stay in the hospital, and then there's a whole bunch in between. So it's a fascinating discipline.
And relevant in the UK because there's been a number of courses just approved for clinical exercise physiology training here. Tracy, it's been really brilliant chatting, and obviously you spent a lot of time thinking about the differences in healthcare and delivery between Australia and the UK. To finish, I'm putting you on the spot because I didn't forewarn you of this question, but if there's one thing that you think in the UK we could learn from Australia for delivering better physical activity or increasing physical activity levels at a population level, what might that be?
Look, I think working at a local level and being heavily involved in co-design. You know, I'm speaking to my own truth here because I don't believe everyone's the same. Not everyone's going to respond to the same medicine, particularly when it comes to exercise. So for me, I really enjoy cycling. I do a lot of cycling. I enjoy hiking. I enjoy the odd gym session, but I'm not an exercise junkie in the way that my two very, very, very active children are, and I'm certainly not a runner. I hate running. You tell me, to go for a run and I'll look at you with a strange look and go somewhere else. And I think that personalisation and regionalisation is incredibly important. So doing place-based co-design, and because I'm passionate about it, I have actually written a co-design framework and a co-design toolkit. It's available on a website called Co-Design for All. You didn't know that was coming, Callum. So go and have a look at Co-Design for All to see a bit more about place-based things, because in Australia that is a growing movement that health promotion agencies are using. And it's really important because a bit like Scotland, having been to Scotland again last year, one of the things that you and I talked about was the difference between cities and country. And in the UK, the weirdness that I hadn't really got my head around was that people of means tend to live in the country in a beautiful house with a big four-wheel drive, and people of lesser means tend to live in the cities. It's often the reverse here in Australia. People in the cities are the ones earning the big money, working in hospitals or banking or finance or universities or whatever. And in the country, some farmers are doing very nicely, thank you very much, but an awful lot of other people are not doing so well. So what resources do they have to call upon when it comes to activity? If you're on a property that's 400 acres or you're on a property that's 4,000 acres, and we have an awful lot of those in this country, enormous properties, what sort of activity is going to get you going? Because a lot of them have quad bikes and tractors and all sorts of other things. So even though they're on a big open landscape in one of the sunniest countries in the world with great weather, they're not necessarily getting up and moving, even though they're travelling vast distances. So it still comes back to that personal prescription of what I like to say, the best form of exercise you can do is the exercise you're going to do. And that will come back to the individual, their situation, their time frame. Because the other big pressure that we have in Australia, being a vast landscape, and often it's very hard for people to get a sense of just how big Australia is. It is enormous. So the state that I'm in, the state of Queensland, will fit the UK in it something like 7 times. And I'm only one state. There's a lot of other states here, so it's a big, vast landscape. As I said, we've become addicted to cars, and, we just need to create healthy environments that allow people to get out more, not be as reliant on cars. So there's a big public transport movement happening in this country as well. And we certainly need to make exercise more affordable. Australia has some of the most expensive housing in the world. It's high quality housing, but it's very expensive. So people's ability to fund a gym membership or whatever else they might be into, yoga, etc., in many instances is becoming quite constrained. And that's where I think there probably is an increasing role for neighbourhood centres, for general practices. I've certainly seen them in America and Canada, where general practices have a separate room where you can do line dancing and Pilates and, all sorts of great stuff that's subsidised by the health insurer. So I think carefully thinking through who the populations are that are missing out and what it is that's going to bring them together, not just for the exercise, but for the connection and for the other incidental education and things like that can go on. It's a challenge we all face, and we've just got to get on and keep being creative, which means talking to the patients and co-designing stuff together.
Cool. Well, it's really interesting, and you've given there's so many thoughts and things to think about. So thank you so much, and a great note to end on. So yeah, thanks for joining.
No problems, thank you. Lovely talking to you again.
It comes as no surprise to me that both Andrew and Tracy highlighted the issue of health inequalities. Health inequalities are growing, and it's a particular issue in health promotion. Those with more agency, knowledge, motivation, time, money are more likely to be able to successfully implement lifestyle recommendations. And so, if done badly or not accounting for a variety of factors, physical activity promotion has the risk of widening inequalities. As Andrew mentioned, in New Zealand, Pacifica and Maori populations have worse health outcomes than European settlers. There's a number of complex reasons for this, and active attempts are being made to address it. Dr. Jason Tujo is a GP in New Zealand. He's a board member of the Royal New Zealand College of General Practitioners. and also a key member of one of their committees looking at addressing Maori health inequalities. I was lucky enough to interview him to discuss inequalities, physical activity, and Maori health. Hi, Jason. Thanks so much for joining me today. I'm gonna just kind of kick off with a meaty question, if you don't mind. And I was wondering if you could tell us a bit about health inequalities in New Zealand, and particularly around Maori health.
Tēnā koe, Callum. Mihi ka ana ki a koe tēnei wā, whai whakaro tātou ki tēnā pātai. It's good to catch up with you again, Callum, and to have this kōrero with you. And I mean, health inequities in Aotearoa New Zealand, and especially for us as the indigenous population, as Māori, have been profound and enduring, unfortunately. So when we think about health inequity for Māori, we look at how that came to be. Firstly, in regards to the consequences of an indigenous population being colonised, but also how those are not only how they originated, but how they're maintained, and then how they continue to have an impact on a lot of our whānau, on our communities across Aotearoa. So that comes down to primarily looking at life expectancy and the differences between Māori and non-Māori. I think there's a 7-year life expectancy gap, and that's certainly different between male and female. But not only just across life expectancy, but also at every stage of life, looking at infant mortality, looking at child and adolescent health, looking at mental health, and not only our young population, but also within within adults, across all the diseases, the cardiovascular diseases, across cancer, across any health statistic that we monitor and report on. So these are, I guess, the ongoing consequences of those base causes of inequities and health inequities. And it's certainly something that we're ensuring that we get the good quality data to maintain and keep a close eye on how things evolve for us as a people, but also the obligations that the New Zealand government has in regards to Te Tiriti o Waitangi and the obligations they have to us as a people who are trying to do the best that we can and trying to live lives and do all of those things that everybody else is wanting to do and to enjoy as well.
It's pretty shocking when you kind of outline it like that. With an interest particularly in healthcare services and primary care, is there any challenges with the way that primary care in New Zealand set up that is perpetuating those inequalities, Jason?
Yeah, so in Aotearoa, primary care is quite broad and getting broader, especially because, as you may or may not know, we're facing a GP shortage here. I think it's just like that across the world, and certainly we're feeling that here in Aotearoa. That's going to be compounded by the fact that in about 7 years' time, I think over 50% of our workforce will retire, and a lot of them are working well past retirement. But they're working because they care about their communities. Some of them have been in the communities looking after 3 or 4 generations of whānau, and they do it because they care, and they do it because they want to be able to provide the care, and the communities that they care for generally are grateful, and that's the kind of care that a lot of our whānau have grown up with, having the same GP, looking after the grandparents, the parents, and the kids. They're kind of that situation is changing, and it's changing rapidly. that's even, I guess, more stark when you're looking into the regions, if you're going rurally as well. It's like that for where I'm from in the Coromandel, where we rely heavily on locums and overseas locums as well, who come to spend some time in Aotearoa, but also in some of the other rural places. We even have some of our nurse practitioner colleagues who are looking after the communities as well. And so there's certainly aspects of that contribute to the widening of these health inequities. And I think there's a number of strategies that have been employed to try and help address that, increase the number of medical students that are coming through, increase the placements for general practice on our program, trying to increase the funding to help support our registrars as they're coming onto the training and things. So, but yeah, there's still a lot of work to be done, and it's certainly all important, particularly when you're talking about those health inequities. And then on top of that, you're looking at that rurality aspect, and then all the socioeconomic factors that compound that as well.
Yeah, and a lot of that resonates, I think, internationally, as you say, those challenges, particularly, with an interest in health promotion. My Churchill Fellowship was around physical activity, but more health promotion more widely. Are there any steps being taken to address health inequalities, and particularly within a Maori population in New Zealand?
I think at a system level, we used to have this thing called the green prescription. I think we spoke about that as well, where we could get subsidised gym membership or gym fees being paid for, or going to the pool and things like that, which I think the only criteria was that you had to be over a certain BMI to be able to be referred for the program. Unfortunately, there was a loss of funding for that particular program, which meant that we weren't able to offer that as an option for our patients particularly in primary care. But there's still an overhang from that as well, with patients still asking about the green prescription, even though it's been out for about 5 or maybe even longer, 5 or so years or longer. So, and outside of that, and things, working in primary care, working in a rural community, there's not much else apart from if there's some of the clinics and organisations who divert some of their funds to be able to support services that allow for patients to become more physically active, like, for instance, having subsidised pool visits or those sorts of things. So, at a system level, I think we're lacking and need more investment into that particular area. Just like any area, we're kind of under-resourced, and at the end of the day, it's our whānau, our communities that suffer as a result of that. But I think, for our people, for Māori, we're quite resourceful, and if there's something that we need to do, then there's always a way for us to kind of make it happen. Even if we don't have the funding or the resources, we just use the tools that we have, and we kind of follow in the footsteps of what our ancestors did when they came here, 1,000 years ago or so. So, and what I mean by that is that, particularly for health and well-being, kaupapa like Iron Māori, which is, a kaupapa, it's the Iron Man, but instead of the Iron Man, it's called Iron Māori. And it's you have those particular aspects to it, in terms of what you're doing with the run, the cycle, and the swim. But they kind of do it in a more kind of whānau-friendly aspect. So one might do the one leg, or they might, there might be a couple of them that actually walk rather than do the run, and it's intergenerational as well. And obviously, we're quite a competitive people, so there'll be some of us who'll be, trying to get the best time ever, and then there'll be those of us who just want to participate. And you've got the, kuia, you've got karawa, you've got the old people who are doing it as well. So, there's those sorts of aspects to it, but it becomes more of a whānau inclusive, family inclusive event rather than just, strictly for those who are trying to beat a world record. Yeah, so I guess, there's other examples where we kind of do those sorts of things to help lift the health and well-being of our people.
One of the things that struck me when we had a coffee and on a sunny autumn morning was that intergenerational aspect of the activity that you do, but also the way in which you have used kind of traditional forms of movement and kind of sustain them and the kind of outrigging. I'm going to get the word wrong, Jason. You'll have to correct me, but you mentioned kind of you and the family do it, but also you have kind of big intergenerational meets, which is a real kind of amazing way of ensuring it lasts through different generations and the legacy continues.
Yeah. So that's outrigging wakama, which is is an international kaupapa. Some call it a sport. For some, it's like a way of life, and I guess a way to go back to some of those sort of traditional ways of keeping active. And we're here in Aotearoa. We had in New Zealand was brought over by a couple of stalwarts from overseas to New Zealand as a way to, I guess, connect people back to the ocean. And my wife and her whānau, they've been a part of the wakama community for, must be going on close to 30 years now. And my in-laws, Sugar and Ben, they've been a part of a club here on the North Shore for maybe 25 plus years as well. And, they've gone to international meets and, they've done well and they've medaled and at these world events and things. And, and same with my wife, she started when she was 11 and she carried right up until she went to medical school and then got busy with that sort of thing. So, but it's a way, for families to do something like a big kaupapa together. I think that's why, she went along to it because both their parents were doing it at the time as well. And now our kids are doing it, and our 14-year-old is paddling. And like I said to you just before there, the 9-year-old and the 7-year-old are out there in the single, going for a paddle as well. And our dad's in there too. So, 17 years with my wife and only just started paddling recently, but it is intergenerational. It goes right from 6-year-olds all the way up to 70 plus, the paddlers and things, so 70 plus years old. So, and I think this year at the national meet, we had one of the biggest with close to 5,000 paddlers just in one area for the sprints. And that usually, they have a world event. This year it's over in Singapore, so there's like paddlers from all over the world who do this as a way to not only to keep healthy, but be in tune with the environment and with the ocean and with the lakes. And it's a good place to be as a community and as a whānau.
Yeah, with family. One of the things that you mentioned when we met was kind of the education you were trying to do with medical students and GPs and GP registrars around kind of Maori culture. And that feels to me like it's really important because if someone comes in and you want to recommend physical activity, knowing, what's available, but also kind of what might appeal to them is really important. Could you tell us a little bit about kind of the programs that you're doing with RCGP New Zealand and also at Auckland University?
Yeah, so we've been fortunate in terms of our kind of, I guess, our learning environments and the people that have helped to pave that way. We had Eddie Harpati Ramsden, who was a Māori nurse and first coined the phrase of cultural safety, which rather than looking at trying to understand and trying to look at thinking about what can I learn about other cultures, is actually doing a more of an internal reflection on on one's own culture potentially one's own implicit biases and things like that impact on connectioning and consultation with others of different ethnicities. And we've also had, Mehana Mason Jury, who created the Te Whare Tapawha, which is a Māori framework that looks at sort of health and well-being and the aspects, that contribute to that, like physical health, like emotional, mental health, like spiritual health, but also the importance of whānau and how that contributes to a healthy person as well. So that's all of those sorts of things have coalesced with other, Māori academics who have looked at things like the Mehana model and the hui process, which are being taught at the medical schools. So it's a model, the hui process is a model of engagement when you're engaging with a Māori patient. And then the Mehana model is an extension of Te Whare Tapawha, by looking at other aspects that are important to all people, or particularly to Māori people, because that's the cohort that had been under investigation or under research with that particular model. So that's been taught in the medical schools now for, I think, maybe 15 years, maybe less, because I don't think it was around when I was coming through medical school, but certainly the medical students who have been coming through now are more aware and more learned in that. So that actually transfers into how our registrars are coming into the program, which is different to when I was coming through as a registrar, and certainly before me, the aspects of how to engage in a culturally appropriate way with Māori patients, because that does have an impact on the relationship, and also how they are with taking advice and information and things. Yeah, so but when you're in kind of smaller communities, you have a bit more of an understanding of what happens in that community, and what avenues that you can recommend and people that you can sort of point them towards. So, for instance, if you're doing things like kapahaka, which is the kind of Māori performing arts and things, and for the last couple of years, there's been a kaupapa called Hauora ki te Ao, which is about improving the health and well-being of kaihaka, of those who are on the stage, and in ways in which they can keep themselves healthy. Keep watching what they eat, making sure that they walk, a certain number of steps and things, and then there's like an accountability aspect that they have. So, yeah, it's I think having an awareness of those sorts of programs helps to, and especially if you've got whānau who are interested in doing something and know that there's an avenue for them to go down through.
It's really interesting, and my final question, I'm going to proceed with possibly some learning points for me that have come out from what you said. One is the kind of importance of continuity of care, and obviously the challenges that the current context of primary care globally has. The second is kind of a cultural understanding and kind of ability to frame things in an appropriate way. And maybe the third is kind of having the time to do it. But I was wondering, are there any kind of lessons that you think we can learn from or that can be implemented internationally from what's happening in New Zealand?
Yeah, I think some of the cool things that have happened within during my time, and I've only been working as a GP or as a specialist GP for 10 years with my fellowship in 2016. But a lot of the wonderful things that have come out of that have been there to help with hauora Māori, particularly, have been things that the communities have driven themselves, or that our communities have driven themselves. So things like hauora ki te ao, things like Iron Māori, things like wakaama, Things, also in terms of overall screening things, one of the kaupapa that we've got over here is, of course, SME or MEA. So it was a way for our women kaihaka to have their smears and things taken. So it's been those sort of community kaupapa driven projects that have been really useful. And I think what we probably need to be doing is getting behind a lot of these kaupapa and properly resourcing them so that they can actually make an impact and an enduring impact on the health inequities that we face as a people. I think certainly we have to continue to keep the government accountable to the obligations under Te Tiriti, and that's something that we're going to continue to do until we no longer, or until we achieve health equity, we no longer need any of these extra things, because actually we're doing okay. But it might not be in my lifetime, and I hope it's in my children's lifetime or my grandchildren's lifetime when I do have some. But I think those are the things that I hope to see, achieve, and contribute to. Both my wife and I, and her mahi as a general surgeon, and in the research aspect that we're both sort of doing as well. It's a long road, but it's certainly worth it when you've got some really awesome things that are happening. You're just happy to be a part of a pretty cool kaupapa.
Yeah, amazing. And interesting, your final point was about political lobbying, which is what I kind of have come back to is the role of healthcare and healthcare professionals within politics throughout this Churchill Fellowship. So a good point to end on. Jason, thank you so much for your time. I really appreciate it.
Oh, fine. Thank you.
I return from the Antipodes to Europe. Interestingly, in the Netherlands, the approach to physical activity promotion in primary care was remarkably similar to that in the UK. The standout difference was the presence of infrastructure to support physical activity, particularly cycling, what it's famous for. However, one place that stood out to me was Finland. The widespread adoption of a systems-based intergovernmental approach was fascinating. Here I am interviewing Eero Kentä, who leads the promotion of physical activity and lifestyle in the social and healthcare settings within Helsinki. Hi, Eero. Thanks so much for joining today.
Thank you, Carl, for invitation for this podcast.
It's a pleasure. Yeah, I'm kind of joining you from an absolute roasting UK. It's a huge heat wave at the moment, so I hope it's not as hot in Finland.
No, you can be sure that in Finland it's always a little bit cold, but it's more fresh. So please to travel here and have a little bit more fresh summer.
Yeah, a good place to recover. Eero, I wonder if you could start by telling us a little bit about physical activity promotion in Finland.
Yeah, thank you for this good question. For me, I think this is a very topical issue, both nationally in Finland, but also in my work in the city of Helsinki. If we talk first about the national context, this is a very topical issue because in January 26, Finland published the world's first physical functional capacity index based on measured population data and developed by the UKK Institute. And in addition of this, a parliamentary declaration was adopted in which all parties in the Finnish parliament committed to the goal of increasing the physical functional capacity of the Finnish people by 15% by 2040. So this is a topic that has efforts over the parliamentary years. And now during this current government program for 23 to 27, we have a program called Get Finland Moving. And this program aims to increase physical activity across the whole population by making physical activity a natural part of everyday life. So as we talk about physical activity, it's not only about sports, or hobbies. It's about all the daily choices you make, environments you live, services you use, and how we can get people moving and more physical with this support. And this program, Get Finland Moving, emphasizes reducing sedentary behavior and strengthening everyday physical activity and creating supportive environments where active choices are easier to make. For example, it's always one person's choice in daily life. Do you choose to go by car from place A to place B, or do you choose to use your muscles, walk or go cycling or whatever? So in every life context, we can make these everyday choices more easier for individuals. And as this perspective, overall, the approach in Finland is more likely shifting from individual motivation towards system-level change that enables active lifestyles. And I would like to mention one more detail about this. Under this Get Finland Moving program, we are, as a one action, we are strengthening this system-level approach as a national education program, which is currently being prepared for health and social care professionals. And I'm very happy to be a member of this expert group, which is preparing this course for the students and professionals in the social and healthcare sectors. And the goal is to strengthen the skills of social and healthcare professionals in promoting physical activity and nutrition as part of their daily client work, not as a separate additional activity, but as a natural part of their daily care work. And this reflects a broader shift that we are increasingly seeing health professionals, social professionals as key actors in promoting an active lifestyle across the entire population at the population level. Because as we know, physical activity has a incredibly effective in prevention, treatment and rehabilitation of physical activity and mental illnesses. So there are a few current examples.
Gosh, it's amazing. I got so many questions, and some of them I'll come on to later.
Yes.
You mentioned changing the environment and focusing on kind of systems level change. I know that you work specifically within the municipality of Helsinki. What are you currently doing in that municipality? What kind of practical things are you doing to address system level change, and possibly even narrowing that down, the environment? What kind of changes are you making to the environment within Helsinki to support people to be more active?
Yeah, in the whole city of Helsinki, we have a welfare plan. We focus in particular on the reduction of disparities in people's well-being and the promotion of daily physical activity and an active lifestyle. And this is whole city's goal to put common effort for promoting physical activity. And this is like a team effort between our different departments. Each department, like the department where I work, social, healthcare and rescue services, have one focus on this. But for example, culture and leisure division have their own perspective how to have these sports services and cultural services for citizens and so on. But what's most important is that all our departments are committed to the common goal of promoting everyday physical activity and an active lifestyle among our city residents. And this is during the current program until 29. And now we have our goals and we are planning the actions how to reach these goals. And about my work in the Department of Social Services, Healthcare and Rescue Services, I focus on promoting well-being and health. My personal role is to support services and professionals by developing tools to aid their work, and for example, by training staff. And in addition, I provide strategic support to the division's management. And in addition of this, I collaborate with other cities departments and national levels. And one main focus is that, as we know, social and healthcare services have thousands of daily encounters every day and millions each year. So considering this volume, how we reach our residents, there is huge potential to promote physical activity within social and healthcare. And for scaling this, our professionals need quick and easy to use tools for discussing physical activity. And we have now developed these tools, for example, the mini intervention model for promoting physical activity.
Could you tell me a bit more about that mini intervention model, Eero?
Yeah, it's a brief advice and discussion about physical activity. And the goal is not to see if the client reaches physical activity recommendations, but more likely the goal is to strengthen individuals' confidence and motivation to be more active in daily life, even a little bit more active. And the ultimate goal would be the recommendations of physical activity. But inactive people benefits the most from doing even a little bit more activities in their daily life. So this is the goal. How could we strengthen individuals' confidence and motivation? And for this, we use motivation intervention model. And in the intervention model, this has been developed to promote physical activity, and it's been seen to be a suitable tool for healthcare work. Even though we have a short time, like 12 minutes in average in health centers, this tool has been seen to be suitable and easy to use in this time of period. And if we record this use of the mini intervention model in a structured way in our client system, electronic client system, Apotti, this information becomes valuable data for knowledge-based decision-making in health promotion at the each levels, like at the unit, organizational, and national level.
Do you know, one of the big challenges I think we have in the UK is healthcare professionals often struggle with a lack of time. And is the model being used? Is it kind of widely adopted across Helsinki?
Yes, this is adopted in different services in social and healthcare, and all the services that see promoting physical activity as a natural part of their work. For example, health station services, social services, physiotherapy, and so on. But also in other services where we can meet our residents, like employment services, for example, and also in educational services, because in the schools and in education we can meet almost every young citizen. So this is a perfect place to also use the physical activity promotion for their mental health, physical health, and to support their learning. So we really see different divisions, different services as a good place to use this mini intervention model. And in the last year, 25, this model was used 3,800 times. But already in this year, 26, this has been used around 5,000 times, and it's just half of the year past. So the use of the model is increasing, and the potential is enormous. So I hope that in 2029, the use would be even more wider and bigger.
That culture that you seem to have created of all health and social care professionals buying into their role in promoting physical activity is really kind of amazing and important. And one of the things I kind of wanted to mention is when we were in Helsinki and probably Finland more widely, one of the things that struck us was that there was lots of cycle paths, there was lots of parks that were invisible places. And so when a health professional is having the conversation, the environment is there to allow the person to go and follow through on that desire to be more active. And I think that's really important. One of the other things when we met on the waterfront you mentioned is that in the municipality of Helsinki, you also encourage your health and social care professionals to be active themselves by giving them a budget to spend on gyms or events, sports events. Could you tell us a bit more about that? Because that really fascinated me at the time.
Yeah, I think we have good insight in studies that if the professional, him or herself, sees physical activity as a important and the professional itself is active in everyday life, it's more likely that the professional also promotes the physical activity for the clients. So it's really important that we have these both two things close to each other. How can we educate professional, train them? How can we get them moved and active in their personal life during work days, during the leisure time, but also how can we support them to promote the physical activity for their clients. So we have a huge section of benefits what our professionals can have, like economic ways. They get this how is it called, like a possibility to go do sports or culture events or whatever, and the organization pays until a specific amount of euros, and this is like tax-free benefit for professionals. Also, professionals can use city bikes for free. This is also like paid from the organization. In addition, we have digital tools. Everyone can download an app for your computer, where this app encourages you to stop leisure time or the sedentary behavior and start doing some little movement at your desk or whatever. And how can we even encourage this culture and behavior that it's okay to feel free to do some small movement, take a few deep breaths or stretch or whatever makes you feel better to recover from your daily work. And it's not like seen as now you're not so effective professional because you're having a break from work. You should see in your unit and in your everyday work group that it's good for you, it's good for your coworkers, and in the end, it's also good for your clients.
Yeah, interesting. That last point you make is kind of about permission, giving healthcare professionals permission to take a minute away from their desk, and maybe even permission to stretch, which might look odd, but if everybody has permission and everybody knows you're doing it, then culture changes.
Exactly.
Look, Eero, I know that kind of time is short, but one of the things that struck me most about Finland, and you've mentioned it throughout every answer, and particularly that first one, is that there seems to be a huge amount of political engagement to ensure that health promotion occurs. And before we started recording, you mentioned a quote by your Prime Minister, Alexander Stroop.
Our president.
President, sorry. Who I'm aware is like an Ironman triathlete and is a huge physical activity advocate. But how has this political engagement happened? Are there, and how could it be replicated in the UK, for example, to ensure that there's really widespread buy-in and engagement in health promotion and physical activity particularly?
I would say that, all political parties must commit to the same goal, that getting people, citizens, clients active. It's not only in it's not only like sport services problem, or not only an issue for health and social services. It's economic issue. It's an issue of how can we support learning, education, and also working. So every party should commit to the same goal, and from every ministry, for example, should have their own perspective. How can this benefit them? So this is the most important thing. We have studies. We have the power of studies that we know how much we can have, like economic. Wait a second.
Economic benefit or cost benefit analysis.
Financial savings.
Yeah.
So that's why you should have for one parliament season, and hopefully over that also a program where everyone is committed, and there's the possibilities to make change. Because if you do actions this year, you see the benefits in few years forward. So it's really difficult if you discuss about money, for example. How can you show that these actions pay off in this prime minister season? Because the benefits can be seen more further in the future. So it's a little bit difficult, but as we know, this will be the end result, and it benefits us all. This should be committed from all parties.
And it takes time, but I really hope it, and it already is, but I hope it's a kind of roaring success in Finland, because you can kind of aspire or inspire the rest of us, and we can all aspire to be more like you. So look, thank you so much for your time. I really appreciate it, and we could have talked for a lot longer because there's so much amazing stuff that you're doing in Finland.
Definitely. Thank you, Cal. It's always a pleasure to discuss with you, and hopefully we can see again in the future. It's really nice to hear how is this same topic going in the UK, and how can we share our interests and experiences between Finland and UK. So thank you so much for having this possibility to join your podcast.
Thanks, Eero. I really hope you've enjoyed listening to Andrew, Tracy, Jason, and Eero, and you've learned something. There's something you can reflect on and take. I wanted to end on a slightly more philosophical note. There's a number of things that I've continued to reflect on and think about from the Churchill Fellowship. The first regards responsibility. How much responsibility does an individual bear for their own health outcomes? So much of what we do in lifestyle and physical activity promotion targets individual behavior. But maybe the environment is important. It's hard to cycle if you don't live in the Netherlands. Linked to that, how autonomous are we in the choices that we make? So much of population-based physical activity seems to be determined by the environment in which we live, and therefore politics plays a huge role. Does the state in which we live, in the UK or elsewhere, Does it prioritize the autonomy of the individual or the autonomy of the free market? I'm not saying either is particularly right and wrong, but sometimes they combat each other. For example, car ownership and the car lobby might restrict the capacity or the ability to put in cycle infrastructure. And finally, there's a question around ownership. Is physical inactivity really a healthcare problem? Is using healthcare just a sticking plaster to try and fix an issue which is much wider and needs to be addressed much further upstream? I don't really have the answers to these questions. They continue to trouble me, but I have been inspired by Finland, appreciating that to make system-wide change, we need high-level political engagement. So I'm going to finish with what's really a call to arms. And that is, whether you're a health professional or a citizen, we all have power and influence to make change where we are. We need to engage in politics, not necessarily party politics, but politics for the small p, whether that's at a local level, influencing local community councils, advocating for things that really matter to you, whether it's meeting with your MP or local MSP to really challenge them and address issues that you've seen locally. Or maybe it's joining a board that is addressing local or national issues. Whatever it may be, please engage, use your voice to promote physical activity throughout and within our communities. Thank you so much for listening. I hope you've enjoyed it, sharing some of my thoughts and with these amazing guests. I'd love to hear your thoughts, so please do reach out, whether it's on social media, via email, or just in the comments below. I've also been really fortunate to have my reflections from this Churchill Fellowship accepted for publication in a book with the publisher CRC Press. This is hopefully going to be released in early 2027. So if you do want to find out more, I'll be sharing some information when it's released on my LinkedIn. Thanks for listening. Hi, it's Callum. I really hope you enjoyed the episode. We are so grateful to the British Society of Lifestyle Medicine for their support in producing these podcasts. And we wholeheartedly share their vision of transforming healthcare and levelling health inequalities through lifestyle medicine. If you want to find out more, please head to bslm.org.uk. Although catering for healthcare professionals, this podcast is for everyone. If you enjoyed it, please share it. And we love hearing from you, so do reach out. Thanks for listening.